Chapter 41, Pediatric GI Dysfunction. I'm going to start by talking about body fluids. So total body water includes intracellular fluid and extracellular fluid. Insensible losses are losses that we can't measure when we do our intake and output, but we know that they occur, and they cause increased fluid intake requirements. And a few of the most common insensible losses that we'll see in the hospital are infants who are placed in a radiant warmer to keep them warm, the presence of fever, or the presence of shock or sepsis. These all increase fluid intake requirements. Pathophysiological conditions may cause decreased fluid intake requirements, and those include conditions such as congestive heart failure because of their retaining fluid, or increased intracranial pressure. So you would see that with a bulging fontanelle. So indicators of hydration status. We're always going to ask the parents, is their pee normal for them? Is it darker than usual? Is it less than usual? Pediatric intake and output, I'm sure you all learned on the unit at the hospital that we're weighing diapers for our diaper wearing children, and 1 gram of weight, fluid weight in the diaper equals 1 ml of fluid. If they're able to pee in the potty, we'll use the collection hats to measure that. Measuring vomit, measuring blood loss. So next time you have a patient who's had surgery, take note of their surgical note by the surgeon, because that always includes an EBL, which is an estimated blood loss. And it may be a range. They may say EBL less than 250 mLs or EBL approximately 500 mLs, something like that. And then sweat is going to be another insensible loss that you're not necessarily going to be able to measure unless it's on the bed sheets. If it's on the bedclothes and you know how much those linens weigh, you may be able to weigh them the same as the diapers and subtract the amount, but usually not. Vital signs are an indicator of hydration status. So the more elevated their heart rate, the more tachycardic they are. Often, the more it means they're dehydrated. Blood pressure, having a blood pressure drop in a child is more of a late sign. It takes a blood pressure longer to drop in a child than it does an adult. And remember, I gave you that little math problem that American Heart uses on their pediatric ACLS. And they say that the systolic blood pressure at a minimum should be 70 plus twice the age. Well, that's not huge. That means that if I'm a little 6-year-old, that at 70 plus twice my age, a systolic BP of 82 is just okay. So really, it's not the only thing we should be relying on. Skin turgor and mucous membranes are huge. So checking the skin turgor, pinching the skin over the chest, and then looking at the mucous membranes, primarily in their mouth and their conjunctiva. Body weight fluctuations are indicators of hydration status. So if there's a sudden loss of 1 or 2 pounds in the course of just a couple days, that usually is from hydration. And then sunken eyes and sunken fontanelles. In our older children, like let's say school age, the sunken eyes with the deep dark circles under the eyes can indicate a sudden dehydration. So when we're talking about a dehydrated child, we want to know what is the degree, how severely are they dehydrated? And American Heart Pediatric ACLS talks about compensated versus decompensated. So compensated means that the systolic blood pressure is still normal. Decompensated is that late sign when it's now dropping. There are different types of dehydration as relates to what's happening with the electrolytes, and this may sound familiar from your adult fluid and electrolyte discussions. So we have isotonic dehydration, which involves an equal loss of fluid and electrolytes. We have hypotonic dehydration, which means there was more electrolyte loss, and so now the body fluids are very dilute. And then we have hypertonic dehydration, which means that they lost more water and that now the electrolytes are elevated and concentrated in the body. When we're doing a diagnostic evaluation to determine the degree and type of dehydration in a child, we're going to do our physical assessment looking for those physical signs of dehydration firstly. We're going to take into consideration what illness is causing this. And then we're going to be checking their electrolyte levels, especially the sodium level. The sodium level is going to tell us whether this is an iso, hypo, or hypertonic dehydration. When it comes to therapeutic management of dehydration, oral rehydration solutions are always tried first. ORS, oral rehydration solutions, and you will be seeing that again, is a common testing item, is a common NCLEX item. So if you get a question, a scenario where a child is vomiting, unless they're literally unstable, unconscious, seizing, something like that, if they're awake enough to put a straw in their mouth, we are going to try this Pedialyte and Gatorade first. Because if they're able to keep that down, even if they weren't able to keep down a bottle, a piece of toast, anything else, if they're able to keep this down, we're going to be able to rehydrate them without dealing with trying to get IV access on a small dehydrated child. If they cannot keep down the oral rehydration solutions after they are attempted, then we revert to IV therapy. When you're starting an IV on a child, they will always receive a fluid bolus first. And to clarify, what is a fluid bolus? A fluid bolus is a large measured amount of IV fluid given one time. So if they're on a continuous rate, that's not a bolus. If you get an order such as, let's say, a liter of fluids over 8 hours, well, that's not a lot. A liter of fluids over 8 hours, that's just 125 an hour for 8 hours. That's not technically a bolus. A bolus would be a large amount. So in adults, we're usually saying 250 mLs over 15 minutes or 500 mLs over 15 to 30 minutes or a liter over 30 minutes to an hour. The way we measure our fluids in children is 20 mLs per kilogram. You're going to want to memorize that because you are going to see that again, not just on my tests, but on NCLEX as well. And pediatric ACLS drills that into your head as well. 20 mLs per kilo is a bolus for a child. You start with 1, reassess whether it was enough. If not, we repeat it. Give a second. Part of our assessment to make sure that we haven't overhydrated the child is looking for edema. So localized edema, peripheral edema in the hands, feet, arms, and legs could be from excessive IV fluids, or it could be cardiac in origin if they're having congestive heart failure from a heart problem, which kids do. Generalized, they could have ascites edema, so they could have that bloated belly from excess fluid in the liver, or pulmonary edema. That is most dangerous when you're hearing just very wet sounding lung sounds all over. If they are having abdominal edema, you should be measuring their abdominal girth every shift to trend that. Once you realize that your pediatric patient is fluid overloaded, they're going to deal with it by treating the underlying problem. And yes, kids can and do get Lasix. Now we're going to talk more specifically about disorders of stomach motility. Diarrhea is very common in children. Some of the causes could be a side effect of antibiotics, or it could be infectious. And this is a reminder that diarrhea spores are resistant to alcohol rubs. So if you have a patient with active diarrhea, you should be using soap and water for your hand hygiene. When we're talking about infectious diarrhea, most of these infections are viral, such as norovirus that has been known to affect patients of all ages. Rotavirus is a very common diarrhea virus in infants and toddlers, and it's an actual vaccine that we give at 6 months old. It's an oral vaccine. They swallow the liquid at 6 months old. But even then, it's not 100%, and especially if they haven't had the vaccine. Very common. When we're doing our diagnostic evaluation for diarrhea, we're going to get the history. When did it start? What led up to it? Traveling recently. Norovirus gets transmitted on a lot of cruise ships. Ebola virus first presents as diarrhea. We haven't had that locally. Hopefully we don't. Contact with animals. So contact with animals can cause, in particular, reptiles, salmonella, which causes diarrhea, or giardia can also come from animals or from pool water. The therapeutic management are going to be assessing fluid and electrolytes and rehydration. So assessing our fluid and electrolytes, that means we're going to do our physical assessment, look for actual signs and symptoms of dehydration, watching our vital signs. Is the heart rate elevated? And then lab test for electrolytes, check that sodium level. Potassium is going to be important too. And then when we rehydrate, we're going to do the oral rehydration solutions first. And if that is not kept down, or it is inadequate, then we will add IV fluids. Diarrhea can usually be cared for at home. It is the more severe cases that they need admitted to the inpatient unit for. Home care is going to be similar to care in the hospital, oral rehydration solutions, perianal skin care so that there's not a bunch of perianal skin breakdown from this acidic diarrhea, prevention of the dehydration, and then the diet is to be advanced slowly to a low fiber, low sugar, non-dairy diet. And that is because those are the things that irritate diarrhea and make it return or get worse. High fiber, sugar, and dairy. Constipation. Talking about constipation through the ages. During the newborn period, the first meconium stool should be passed in 24 to 36 hours. If it's not, then we're looking at something diagnostic with the colon to see if there's an actual diagnosable motility disorder. During infancy, constipation may occur related to diet. It is less common with breastfeeding. If the infant is getting constipated from their formula, you may need to change to a different formula and see if that helps. Sometimes taking iron out of the equation helps. Childhood constipation can be environmental. It can have to do with what they're eating. It can have to do with their environment. Sometimes they are intentionally holding their stool. Maybe they don't want to go while they're at preschool. Maybe they only want to go where they're at home. Maybe they don't want to be helped in the bathroom by the babysitter. Maybe they only want mom or dad. So that happens. For our management of constipation, we're going to encourage a high fiber diet with plenty of fruits, vegetables, and whole grains. And we're going to limit constipating foods like white bread, white rice, any white grains, and cheese. Cheese is a big offender. Stool softeners or laxatives may be needed. All of the over-the-counter stool softeners and laxatives come in child versions that can be used. And in the most severe cases, if we're looking at some sort of an impaction or plug, may need to give an enema, and we can give Fleet's enemas to children. They have a child-size one. For our long-term care management, we're going to be thinking about the possibility of fissures, and anal fissures are traumatic perianal cracks around the anus that may have a little bleeding, and it comes from the passage of hard stool. So if a child was constipated and parent reports that they saw some blood when they did pass the stool, that's usually what it's from. And the bad thing about that is it makes it more painful to go to the bathroom in the future, and so it's gonna just reiterate that cycle of holding of the stool. And that's when softeners and laxatives are important. If someone's been struggling with constipation during childhood, this is going to require a lifelong mindfulness to ensure that this is addressed and mitigated throughout adulthood. Hirschsprung disease is a congenital abnormality. It's also called congenital aganglionic megacolon. It's a mechanical obstruction from inadequate motility of the intestine where the sigmoid portion becomes dilated. The incidence is about 1 per 5,000 live births, and it is more common in boys and children with Down syndrome. And what is actually happening is there's an absence of some motility cells called ganglion cells in the colon. And here we have an illustration of what happens to the sigmoid when it distends. And it's distending because it's becoming full. Things aren't able to be moved. So these ganglion cells are missing from the rectum and the proximal colon, and it causes an accumulation of the stool in that distended portion. The anal sphincter, the internal anal sphincter, is unable to relax. So there's an internal anal sphincter and an external one. And this causes a great potential for an infection called enterocolitis, where the colon becomes inflamed because of the presence of that infectious material, that bacteria-laden stool that's not moving. Most cases are diagnosed within the first few months of life, so in the newborn times. We're going to see abdominal distension, constipation, and vomiting. And the vomiting is because food has nowhere to go. Everything is backed up. So the provider will need to take a complete and careful history, and then it'll be diagnosed by a X-ray barium enema studies. Another study that they're sometimes able to use is called an anorectal manometric examination, which is basically a pressure testing to see how much pressure is in the colon. And then a rectal biopsy actually confirms the absence of those ganglionic cells. Once the affirmative diagnosis of Hirschsprung's is made, multiple surgeries are needed, and it's usually going to be a minimum of 2 because we have 2 stages. We have a temporary colostomy, and then we have the second stage, which is the pull-through procedure. So what they're doing is they're removing the portion of large intestine that they've identified to be missing those ganglion cells, and then they are reattaching it, the portions that do. As you can imagine, after a reattachment procedure, dumping syndrome becomes an issue because the food matter has less distance to travel from one end to the other, so that needs addressed. On the other end of the GI tract, we're going to talk about general vomiting now. Therapeutic management of vomiting includes figuring out a cause and treating it, and the cause of vomiting is usually viral. We want to prevent complications from electrolyte imbalances, and the one that we're going to see the most is going to be low sodium and low potassium. And the presence of low sodium and low potassium can cause seizures, and it can cause cardiac arrhythmias respectively. So we will replace the fluids. If potassium needs replaced, we can replace the potassium in the fluids as well. Antiemetics like Zofran, if that's needed. And again, we're going to be trying oral rehydration solutions before IV fluids if possible. And then the advancement of the diet is going to look like clears to bland. So our primary objectives with care management are going to be the electrolyte monitoring, reducing the vomiting, and preventing aspiration. Gastroesophageal reflux, common in children. This is a transfer of the gastric contents into the esophagus, and it occurs in everyone in some measure. What makes it abnormal here is the frequency and persistency with which this is happening. This can occur intermittently without actually being called gastroesophageal reflux disease, and this can occur with or without regurgitation of food contents. So our therapeutic management of gastroesophageal reflux, this is very common in preemies because the valve, the lower esophageal sphincter that prevents the reflux of stomach contents into the lower portion of the esophagus is immature. So this is common in them, and they will often place an NG or OG tube for a few weeks and allow this sphincter to mature. H2 blockers like Pepcid and Zantac and proton pump inhibitors like Protonix or Prilosec may be used. In our more severe cases, there's a procedure called a Nissen fundoplication where the entire area is tightened. The top of the stomach is wrapped around the bottom of the esophagus, and it is tied in there very tightly. They tighten up that sphincter, and these patients who've had this procedure may be unable to vomit afterwards. Long term, if it's a very severe case of GERD, a G-tube may need placed through the abdomen wall. It's not uncommon at children's hospitals to see children getting a Nissen fundoplication procedure with a G-tube placement. The good news is that they can grow out of needing that, and that can be reversed. Other care management that we're going to apply to all of these patients are to keep the head of the bed elevated at night. That mitigates how far the regurgitation is going to happen and potentially prevents aspiration. Gentle but thorough burping after feeds for infants. Thickened liquids rather than thin ones. Careful not to overfeed, and a low acid diet. There's a little illustration for you of the Nissen procedure. There's a little illustration of a common G-tube system for very small children called the Mickey button. And if you click on that link, you'll be able to watch a demonstration of how it works. Some common nutrition disorders in children include vitamin imbalances, mineral imbalances, and risk for growth failure. Some conditions that place a child at higher risk for growth failure include cancer, HIV, sickle cell disease, cystic fibrosis, and low birth weight. And we will talk about those top 4 disorders in their respective sections later in the course. Care management for a nutritional disorder includes paying attention to the dietary reference intakes. So are they getting the recommended intake amount of the different vitamins and minerals? Careful and close trending of their plotted growth charts, and looking at the WHO and the CDC recommendations. And just another reminder that breastfeeding is encouraged for the first 6 months and preferably for the first year, after which time cow's milk can be introduced. Marasmus is the name for severe acute childhood malnutrition, and it's primarily diagnosed as a protein malnutrition. It is a significant problem in underdeveloped countries where children have difficulty consuming adequate enough amounts of protein. This kwashiorkor is the name for malnutrition characterized by abdominal distension and liver strain. So those are those really sad pictures of children with the bloated stomachs that we see. Marasmus is diagnosed by plotting growth charts and then also testing serum albumin and vitamin mineral levels. Therapeutic management is going to include interprofessional care management. Moving on to food sensitivities, we're going to talk about the difference between food allergies versus food intolerance. So food allergies are characterized as causing consistent vomiting, rash, or anaphylaxis, which is airway swelling with tachycardia. Food intolerance is a little less life-threatening. It's characterized as abdominal pain, diarrhea, and gas. So some of the common food allergens that we see in kids are fruits, nuts, dairy, and soy. Celiac disease is a small intestine allergy to gluten that's confirmed by a biopsy. Allergies to most of these can be confirmed by a biopsy or a skin test or actually a blood test. Food intolerances include commonly foods such as lactose or gluten. And there are actually 4 different types of lactase enzyme deficiency that they've identified that can cause lactose intolerance symptoms. Food intolerances are identified by symptomology. They're not always responsive to skin or blood tests, and it's not something that can be seen on biopsy. So it's mostly confirmed by elimination diet, eliminating that food and seeing if symptoms improve with avoidance of that particular irritant. This is an example of what happens in celiac disease. So we're talking about the small intestine, and the normal lining has that villi that absorb nutrients. When a patient with celiac disease is exposed to gluten-containing foods, the villi collapse and flatten out, and they're not able to absorb nutrients, and it causes severe abdominal pain, vomiting, diarrhea, and it can cause bleeding as well, bloody stools. So this is a fairly severe condition that's diagnosed by small bowel biopsy, and it's treated by strict avoidance of all gluten-containing foods. Recurrent and functional abdominal pain is something that we'll see with a lot of kids. This is just kind of a catch-all diagnosis for abdominal pain without a immediately fixable cause. The cause could be psychogenic. The cause could be something organic that we have yet to identify. So when we're doing a diagnostic evaluation for this, we have to think about history. We have to think about physical presentation, and then there will be lab tests to rule out other conditions. Therapeutic management is going to involve psychological reassurance, things to reduce symptoms, and then encouragement to consume high fiber. Care management is going to be explaining pain, Again, that reassurance and heating pad is often found to be effective for this type of abdominal pain. Irritable bowel syndrome is a functional GI disorder. This could be alternating diarrhea and or constipation, and it's often food related. There's often associated a large amounts of flatulence and bloating, and care management is going to involve dietary management, avoiding foods that are irritants. It may involve supportive medications such as antidiarrheals or stool softeners, laxatives for those who are constipated, and maintenance of hydration, since that can fluctuate. Acute appendicitis. Acute appendicitis is an inflammation of the appendix, and the cause is usually bacterial. So with acute appendicitis, the usual treatment is to go in surgically and remove the appendix and then send it for pathology testing, and usually the testing will confirm that it was a bacterial accumulation. Initially, the presentation is going to look like periumbilical pain, but then after a few days, the pain is going to migrate to the right lower quadrant, which is also known as McBurney's point, the point overlying the appendix. Rebound tenderness is cardinal. So rebound tenderness is when it's not tender when you push in, but it is tender when you release after pushing in. Nausea, fever, and elevated white blood cell count. So diagnosis is based on an elevated white blood cell count, and then an ultrasound or a contrast CT is best. So if the white blood cell count is normal, there's no inflammatory process, and imaging is not indicated. It's most likely a viral gastroenteritis causing the symptoms. So many times if we have a child with periumbilical or right lower quadrant abdominal pain in the emergency department, we will wait on the white blood cell count before putting them through a costly and potentially uncomfortable test for them. If the white blood cell count is elevated, they do need imaging. Lots of parents prefer ultrasound because it's faster and it's less invasive. But the problem with ultrasound is it can't always visualize the appendix, so you don't always get an answer either way from that. The contrast CT is the best. The contrast CT, however, is a difficult test to do for a person having abdominal pain because they need to drink a certain amount of the metallic tasting oral contrast and wait a few hours for it to move through all of the intestines. If you're vomiting, you're not going to be able to hold that down. Also, good luck getting a kid to drink all of this nasty tasting stuff. And we can mix it with other things like juice or Gatorade to try to make it taste better, but it doesn't always work out. If the patient is vomiting, they will sometimes be able to administer the contrast rectally through an enema. But again, it doesn't provide as great of an image as drinking the contrast and letting it move through the intestine does. So sometimes you're in between a rock and a hard place during this diagnostic evaluation phase of the visit. Therapeutic management, observation versus surgery. So if the tests are unclear and we don't have a clear-cut diagnosis of appendicitis, they may observe for a few hours to a couple days to see if it becomes more looking like appendicitis or if it improves. Once the affirmative diagnosis is made, though, they will go to surgery. The purpose of surgery is to remove the appendix to prevent it from exploding, to prevent it from swelling up to the point of rupture. There are different schools of thought on what to do once it has ruptured. So if the patient waited too long to seek treatment, or they weren't able to make an affirmative diagnosis in time, or if the appendicitis just happened to progress extremely quickly and they weren't able to prevent rupture, there are two different approaches. One approach is to open up the abdomen and to lavage, to saline wash out the abdominal cavity to try and remove some of that infectious material. Another school of thought is to just let it close and to treat with aggressive antibiotics. So it really depends on the institution whether or not they're going to be going to surgery once it has ruptured. The majority of cases, though, we are able to get them into surgery before it ruptures and then able to get them home in a day or so. For someone who's going into surgery, they're obviously going to be NPO before the procedure and immediately after. They're going to be receiving IV antibiotics, IV hydration fluids, and pain management. After surgery, the main thing we're looking to see is that they're passing gas, they're having bowel sounds, and that they're able to tolerate ice chips. Once they're doing these things, then we can slowly advance the diet and discharge them home. The patients who end up staying in the hospital longer are the patients who aren't passing gas, who aren't having bowel sounds, and who aren't able to tolerate ice chips. And a lot of them develop what's called ileus. And ileus is just basically that the bowel is asleep. It's not moving things through. And when that happens, they're going to have a pooling up of stomach acid in their stomach, making them vomit. So the way that is best treated is to have an NG tube on low suction to remove that acid and to let the bowel do its thing to heal and rest so that it can start moving again when it's ready. So there are certain patients, if their case was very severe, like let's say they did rupture and they were having a whole lot of vomiting before surgery, a lot of surgeons will place an NG tube during surgery, and that's nice. What's not as nice is when you get your patient back from surgery who you think is going to do well and go home in a day or two and they can't, and then you end up having to place an NG tube on this child with an abdominal incision. That's a bummer. But usually once the NG tube is placed, it helps them get better fairly quickly, more so than without. A little illustration of where the appendix is. Meckel's diverticulum. Meckel's diverticulum is a remnant of the fetal mesenteric duct. This is the most common congenital malformation of the GI tract. It occurs in 2 to 4% of the population, and it will cause ulceration, bleeding, and intestinal obstruction. So there's a little illustration to you of what that looks like. That little unneeded vascular portion of tissue causing a problem there. So that's going to need surgically removed. So how do we identify that that's the problem? Diagnostic eval is going to be that contrast CT we talked about, or if the facility has the capabilities, there is a nuclear med test called radionucleotide scintigraphy. If there are signs and symptoms of infection, and there often are, they will give IV antibiotics before and after the surgery. Our care management is going to include IV hydration fluids, keeping them NPO before the surgery and immediately after. There will be an NG tube, and also pain management, incisional pain management. Inflammatory bowel disease, not to be confused with irritable bowel syndrome, IBS. Inflammatory bowel disease is more severe. It includes ulcerative colitis and Crohn's disease. These are autoimmune disorders, and the pathophysiology looks like bloating, pain, blood in the stool, and elevated white blood cell count. So remember, bloating, pain, and blood in the stool can also be a symptom of celiac disease. Not the elevated white blood cell count, though. However, all of these are going to be diagnosed by a scope with biopsy. The therapeutic management includes medications such as steroids and immune modulators such as Humira. Nutritional support, the diet needs to be low acid and low residue, usually low fiber, looking to prevent those diarrhea flares. Surgery is sometimes needed to remove severely damaged areas. And the prognosis depends on early specialty intervention. So the sooner this is caught, and addressed properly, the better the prognosis. I remember a time where a diagnosis of Crohn's disease was pretty much a death sentence. However, that's when they were diagnosing it in adults. It seems like the earlier they're able to diagnose it, the better chances the person has to lead a good quality of life and longer. Emotional support is needed because this can be very disruptive to the person's lifestyle and even potentially mental well-being with the amounts of suffering that may be involved before symptoms are controlled. Peptic ulcer disease can be an acute or chronic condition. The etiology is thought to be an excess in hydrochloric acid, such as happens with untreated GERD, or such as also happens with uncontrolled stress. The pathophysiology is going to look like sharp epigastric pain, which may be worse after eating, with or without vomiting and reflux, and there may be some bleeding. So there may be blood in the vomitus, or there may be a little bit of blood in the stool. This is diagnosed with an upper scope. The therapeutic management usually involves administering a protectant called carafate or sucralfate, and this is a chalky substance that is ingested 4 times a day, 30 minutes before meals. So it's kind of an obnoxious schedule to keep up with, but it's very healing to coat that area before eating. Administration of an H2 or proton pump inhibitor to control that excessive hydrochloric acid that's eroding the tissues, and stress management. Hepatic or liver disorders usually involve inflammation of the liver, and this can be acute or chronic. Some of the common causes include viral hepatitis. So any one of the hepatitis that we've talked about, A, B, C, or others, can be autoimmune in cause. It could be a metabolic disorder. It could be hemodynamic, such as a blood disorder, such as sickle cell disease. Or it could be idiopathic, meaning the cause is unknown. Just a review of the types of hepatitis. So hepatitis A is the fecal oral route, and it's often caused by consumption of food that is contaminated with animal feces. And this is an acute illness. So this is a short-term one that comes on severely but then does get better. Hepatitis B is chronic. It is a blood-borne illness. Once it's contracted, it's there for life. And this is prevented with the 3 series vaccine, the first of which is ideally administered before leaving the hospital as a newborn. Hepatitis C, also chronic, also blood-borne and lifelong. This is the most common one that we see, mainly because there's no preventative for it. There are new experimental medications for adults that are out on the market now. They're not cures, they're just to help mitigate symptoms and decrease that viral load to keep the active viruses in circulation at bay. Hepatitis B is a secondary infection of a hepatitis B patient. These D, E, and G are much less common. E is the fecal oral route found in underdeveloped countries, and then G is bloodborne, but it is newer and still rare in our country. The symptoms of hepatitis may not be present if the person is just an asymptomatic carrier, and that can go on for years and years indefinitely. If it's acute, such as hepatitis A, or if it's an acute flare of a chronic one, there will be vomiting, abdominal pain, that abdominal edema distension, that ascites edema, yellow skin, that jaundice from the elevated bilirubin levels, and yellowed eyes, which is called icterus. For our diagnostic evaluation, we will test the liver enzymes, which are the AST and ALT blood tests. bilirubin panel, CBC, hepatitis antibody and antigens, abdominal ultrasound, and possibly ERCP, which is a biliary duct scope. Most treatment is supportive. There typically is not medication available that directly combat the hepatitis viruses. The exception being some of those newer drugs I mentioned for Hep C, and then during a Hep B acute flare, they will administer antivirals and find that that helps alleviate symptoms sooner. Prognosis really depends on severity of symptoms and how early intervention was initiated. Cirrhosis is end-stage chronic liver disease. It's often found in alcoholic adults, and it can be found in children if they have a congenital liver problem or if they've had untreated hepatitis. So this is something that we see more so in children in underdeveloped countries whose hepatitis wasn't effectively prevented or treated. Once someone is in end-stage liver disease, they need placed on the liver transplant list. Symptom management is going to be supportive. It's going to include close weight tracking to see what is happening with the fluid levels. And then oftentimes they will regularly do a procedure as needed called the paracentesis, which is a needle tapping of the abdomen and draining off of edematous fluid to relieve the pressure and discomfort associated with ascites. So we have the illustration of the paracentesis procedure. You can see the very bloated, fluid-filled abdomen is being tapped first with a needle, and then they can place a little drain, and this is attached to negative pressure vacuum containers, similar to the vacuum containers you do blood tests with, but very large glass bottles that will collect that fluid until they've stopped filling, and once they've stopped filling the bottles, they will remove the excess and bandage the area. Biliary atresia, sometimes called extrahepatic biliary atresia. The cause is unknown. It is a narrow bile duct. And what this usually looks like is an infant that appears healthy at birth becomes jaundiced for unclear reasons, and then jaundice does not improve with phototherapy and traditional treatment. This is diagnosed through the ERCP, the bile duct scope, and surgery is called a Kasai procedure. The Kasai procedure is a hepatoportoenterostomy, where they're basically placing an internal tube to drain that excess bile. If left untreated, this will result in cirrhosis and liver failure. Here we have our little illustration of what the Kasai procedure does to create a route to drain that trapped bile from the liver so that it's not damaging the liver and raising bilirubin levels and causing a constant state of jaundice. Cleft lip and cleft palate. These are facial malformations that occur during embryonic envelopment. There's many factors for it. We know that some teratogens, certain drugs, may make it more likely. Sometimes there's an inherited factor. Maybe mom or dad had this. They can have just a cleft lip, just a cleft palate, or both. There are associated feeding difficulties as an infant and often speech impairment as well, left untreated. So here we have our illustrations of, you see the infants with the different degrees of cleft lip, and then we have the illustrations of the normal palate and the different types of cleft palate. There are special nipples to go with different kinds, and here are a few of them. Surgical repair is done between 6 and 12 months for a cleft lip and between 12 and 18 months for a cleft palate. So the palate is a little more invasive of the surgery than the cleft lip, and we need to make sure that the infant is mature enough that the anesthesia risks and surgery complications are decreased, but that the defects are not yet interfering with speech development. So you'll recall a couple of our conditions, like we talked about the narrow bile duct or the megacolon, that these are emergencies that need addressed. If we're able to successfully feed and have good weight gain, there's no reason to rush a child to surgery as a very small infant. And this is one of those scenarios where we can feed the child. Even in a severe scenario of having an OG tube, we can feed the child until they're mature enough that it's safer to operate. But again, we want to make sure we do so early enough that it's not interfering with speech development. So post-operatively, the head of the bed is kept elevated because of drooling. We don't want them to aspirate on their secretions. Saline irrigations are done of the incision area. Elbow restraints are placed to prevent them from touching the surgical site, and we'll have a picture of that in a moment here. Ointment is applied to lip sutures to decrease lip scarring, and they can have a soft diet. So here's an illustration of a little girl who just had her cleft lip repair, and she has the elbow restraints on that are going to keep her from being able to grab at her lip sutures. So that's a pretty classic pediatrics thing, elbow restraints for the cleft lip, cleft palate repair. So you'll want to be familiar with the nursing interventions for post-op care after cleft lip, cleft palate repair. Esophageal atresia and tracheoesophageal fistula. We talked briefly about these in a prior lecture. So esophageal atresia is failure of the esophagus to develop into one continuous passage, and tracheoesophageal fistula is failure of the trachea to separate from the esophagus into its own distinct structure. So these can occur separately or in combination. It's congenital. There's a huge aspiration risk. The newborn is going to be intolerant of feeds. It's diagnosed by imaging, possibly scopes, and because of the huge risk of aspiration, this is a life-threatening surgical emergency that they need taken to surgery for. They're going to be NPO before and after surgery. They may need to be on intravenous nutrition, TPN, for a while. And then once the surgeon says that it's okay to do so, a couple days after repair will be the time when tube feeds can first be introduced. So here we have that picture again of the different types of esophageal atresia and tracheoesophageal atresia, and you can see how these will really create a huge aspiration risk. Hernia is a protrusion of a portion of usually the intestine through an abnormal opening in the abdominal muscle. There is a danger of incarceration or strangulation, and basically what that means is that the intestine is situated in such a way that blood supply is being cut off to it, and that area is turning gangrenous. So that's an emergency. Some of the different types of abdominal hernia are the diaphragmatic, which is up through the diaphragm going into the chest. The abdominal wall, which is the umbilical, is most common. And there are little babies with just a tiny little umbilical hernia that doesn't need intervention. It just needs noted and assessed and monitored. And then inguinal canal would be groin or testicular hernias. If the hernia is reducible, meaning you can gently press on it and push it back in to be flush with the abdominal wall. Then it's just monitored. It may improve on its own. If it's not reducible, if it does not go anywhere when pressed on, they really need to weigh the risks and benefits of surgery, if surgery is actually needed right away or if they can wait for a bit. It's an illustration of the umbilical hernia for you. Hypertrophic pyloric stenosis is a constriction of the pylorus sphincter from the stomach to the small intestine, and there's obstruction of the gastric outlet. So this looks like projectile vomiting after feeds and palpation of an olive-sized mass above the umbilicus. So you will want to remember that. Pyloric stenosis, vomiting, and an olive-sized mass. It's diagnosed through barium contrast imaging, and it requires surgery to fix as soon as possible. There's a little illustration to you of what's happening, that is being closed off and it's creating a palpable mass. Intussusception is when one piece of an intestine telescopes into another. It is the most common cause of intestinal obstruction in children ages 3 months to 3 years. Sometimes it's due to intestinal lesions. Other times the cause is unknown. The symptoms are severe abdominal pain, vomiting, and current jelly stool. And that's the hallmark, those current jelly stools, because of blood and mucus. So you'll want to remember this: intussusception, telescoping of the intestine, current jelly stools. It's diagnosed by ultrasound or contrast CT. About 1 out of 10 will spontaneously resolve themselves, and that's great when that happens. The good news is it doesn't usually require invasive surgery. Many times they can use a barium or air enema to straighten it out. So here's a little illustration for you of the telescoping intestine and then the current jelly stool. Malrotation, that's an abnormal rotation of the intestine around the superior mesenteric artery during embryonic development. And volvulus is a twisting of an intestine around itself, compromising blood supply to intestines. So both of these are dangerous and require surgical intervention. There are a number of different anorectal malformations, anywhere from simple to complex. The problem with these is that they oftentimes lead to contamination of the urinary tract with stool bacteria, causing frequent UTIs. So surgical correction is often needed for these. Here are a few examples of those. So in the first one with the female, the bladder, vagina, and colon are all coming out to the same hole. On the second example with the female, it's just the vagina and colon that are coming out to the same hole. So that's a little less of a UTI problem there. And then on our example C with the male, the rectum is routed through the down through the urinary tract. So that's going to be a huge infection problem as well. Malabsorption syndromes are characterized by chronic diarrhea and malabsorption of nutrients. It may result in that failure to thrive, and it's usually classified as being an anatomic defect, so an anatomy problem, or a biochemical defect. Short bowel syndrome is one such malabsorptive disorder that is anatomical, and it results from a decreased mucosal surface area for absorption of nutrients. And this often occurs after a small bowel resection or removal of small bowel. So nutritional support is going to include supplements, management of any dumping syndrome. In more severe cases, intravenous nutrition via TPN. There may be a long-term need for a PICC line. Prognosis depends on severity, and it requires an interprofessional care team for management. And here we are wrapping up this discussion with a sample test question. And it is, what type of dehydration is defined as dehydration that occurs in conditions in which electrolyte and water deficits are presently in approximately balanced proportion? And the answer is A, isotonic dehydration.